I am going to speak to us, you on the uh, my presentation, please. Complications in the small incision surgery. See, uh, the complications definitely are there in every type of surgery. So here you can see the uh, whenever you are going to the surgery, then the complications and problems part of each and every surgery, and more for the beginner. So prevention is better than the cure. We always say that, and to anticipate the complication is to take measures to prevent them. It means we always say that the experience is always counted whenever you are thinking of the complications in this. So the complications are seen in every step of the SIC. That may be in the wound construction, that may be in the rexis, whenever you are doing rexis, hydrodissection. So then the nucleus management, then the complications due to the instrumentation. So it means everything can lead to a complications. So the complications, you can see the posterior capsular rupture without the vitreous loss, with or without the vitreous loss, or you can say the post-operative problems, you can see the corneal complications also. So you can, there are corneal complications can happen, and the how this happens. See, if it is wound is too long at the funnel, you can see the corneal folds, less visibility, and there is endothelial damage. So what happens, if your wound is 2.5 millimeter, not just 2.5, but it is 3 millimeter or more than that. So what happens, then we can't see inside the cornea. You see so many folds in the cornea, and those folds can trouble us for the visibility, and they damage the endothelium whenever you are doing it. Then there is a too short, or you can see the incision. What happens, it is not in the cornea, it is just at the limbus, and when it is just at the limbus, then every time iris will come out. Every time, whenever you are doing anything, any instrumentation, then the iris will come out, and then there is no self-sealing. So it should be in the cornea, so that it will self-seal. Now too wide, if it is a too wide, what happens, sometimes you get only the small incision parallel to the limbus. Now when it is parallel to the limbus, then the always what happens, the astigmatism is more, but the iris gets prolapsing every time. And to avoid that, again we will have to see that the width of the incision, it should be, you can see the minimized, and if it is too narrow, sometimes what happens, now we are thinking of the phaco, and in the thinking of the phaco, we are doing the SICS. So we always feel that 2.8 millimeter or 3.2 is very large incision, and accordingly in the phaco mindset we do the SICS, and when we do the SICS in phaco mindset, the incision is very small and nucleus will not come out at all. So that is what happens. So whenever you are doing the phaco SICS, you do it in the SICS mindset and not in the phaco mindset. So that is important, because it should not be too narrow incision. Now here the what happens if it is too posterior, when it goes behind to 2.3 millimeter behind, then it is very difficult, that it becomes like a nucleus is inside the like overlap like that. It means nucleus is inside the tunnel, so nothing is seen. Edges of the nucleus are seen in, but outside edge is not seen, and so you are unable to remove the nucleus. And too forward. So what happens, sometimes few people they do near the limbus or just near the cornea, and so if you do that, then there are so many corneal folds, and then also the integrity of the tunnel is not there. So integrity of the tunnel is also important. It means if you know the steps, you can predict the complication of the step, and you can go ahead. So here the wound construction, see too superficial, you get the buttonhole. See here there is a buttonhole seen, and once there is a buttonhole, then it is very difficult that this you will have to then go deep to that, to the buttonhole, and then you can, in the second plane you can operate. Or you can see the hyphema. Now sometimes what happens, you can see the perforation and hyphema whenever you are doing this. Now here you will see the too superficial, you can see. Now here you see sometimes the shape. So it is very important whenever you are doing this, the shape should be frown, or you can say the modified frown. If it is a smile and horizontal, that definitely gives a tunnel which is not properly, you can say, the self-filling tunnel. So we will have to see that the tunnel should be self-filling, and if it is self-filling only, then only the tunnel is good and you should go ahead. Now here the premature entry, if there is a, what happens, we always dissect the tunnel, and when we dissect the tunnel, there is a premature entry. Now once there is a premature entry, what happens, there is iris prolapse. Now it is to begin with, and when iris is coming out, then total surgery got messed up. And so for that we will have to avoid, there is iridiolysis, it occurs, choose a superficial plane, dissect it and properly, or you can have a new place, you can just suture there and go at the new place, and then the another tunnel, so that your surgery can be complete. Otherwise it is difficult to complete the surgery. Then you can see the wound construction, it is a too narrow incision. Now see what happens here, the nucleus is more than the incision size, and because of that it is very difficult. Now what happens? Whenever you are extending, if you extend like this, what happens? Your astigmatism is much more. And so whenever you are extending, you will have to extend inside. So don't extend outside. If you extend outside, then that will give rise the more astigmatism. Why it is not coming? It is not coming because internal incision is smaller. See, the engagement of the nucleus is not from outside, engagement of the nucleus from inside. So every engagement in the body should be from inside and not from the, in our life, all engagements should be from inside. If the engagements are from outside, they are not permanent. Those are, we can say. So this engagement should be inside. So increase the tunnel inside, automatically that will come out, and see the, or otherwise better to convert to the ECC. Now keeping above problems in mind, so the proper placement, shape of the incision necessary for the good result. So always remember, if you want a good result, then the shape of the incision, size of the incision, internal opening of the incision, it means everything of the incision is very important. Now what happens, sometimes you get the iris injury, the iridiolysis or iris shaping. Then there is a secondary meiosis. So what happens if your tunnel is not in the cornea and you are touching every time to the iris, you are not doing anything. But whenever instruments are going in, you are touching to the iris, and when you are touching to the iris, then there is a, you can say, meiosis, and then once there is a meiosis, it is difficult. Now, but yes, we can now use phenocan, and that can help us. So now see, if there is a tunnel, you can see here, always better to suture the tunnel. It is not important that it is a sutureless surgery. It is a less suture surgery. Here, if you suture it, that will reduce the astigmatism and patient will be more happy. So it is better to reduce the astigmatism than any other thing. So it means you should not be just feeling that I should not suture, but I should suture it properly, and then we should go ahead. So here the rhexis, see what happens sometimes, you have got the habit of phaco emulsification. Why? Because there the 5 millimeter incision is sufficient, but here the nucleus size is 7 millimeter to 9 to 10 millimeter, and in that again you will have to rotate the nucleus and bring it out. And if the rhexis is small one, then the nucleus will not come out, but that nucleus will go behind one, or there may be you can say the subluxation of the nucleus, or you can say zonular dialysis. So many things can happen because you are trying to remove the nucleus in the anterior chamber, but it is not coming because the small size of the, you can say, the rhexis is there. So to avoid that, your rhexis should be larger, and see, once the rhexis escape is happening from the periphery, you go to the other side and do the rhexis, don't go to that side. Otherwise that is going to be in the periphery and that is going to extend. Why it is happening? Because the intraocular pressure is not maintained here, and if you are doing with the AC maintainer, then it is possible, or otherwise it is better to put visco twice or thrice and again maintain the anterior chamber, and then you can do the rhexis. Now here hydrodissection, always remember that at one place, no, you must, if it is a immature cataract, see the wave. If it is not immature cataract, multiple places you should do the hydrodissection. It is not required that at one place only you should do hydronucleus should come out. At 2-3 places you can do the hydrodissection, and once you do it, then the nucleus can come anterior. Otherwise, if you are doing it, then it goes behind. There may be a PC tear and there may be a nucleus drop. So it is better that you should do gently the hydrodissection in the multiple quadrants. Then the nucleus management, see what happens, the may be difficult due to the faulty hydrodissection, because nucleus is not separated. So whenever you are removing, before that you should see the nucleus is rotated or not rotated, and if it is rotated, then only you should go ahead. Then due to the small pupil and small axis, these both are small, it is very difficult to bring the nucleus out, and then the PC tear, and sometimes you get the nucleus drop also. Now see what happens in that, here the inadequate external incision also sometimes troubles you. So here you will have to extend, and that extension always helps, otherwise there may be a PC tear. So we will have to avoid the posterior capsular rupture with or without vitreous loss. Yes, it is always happens, and so can occur at any stage of the, you can say, your surgery. So always remember that whenever you are making it, then you get such type of complication, and you must avoid that. Now the posterior capsular rupture, and if it is ruptured, you can get the, you should now do the anterior vitrectomy, see there is vitreous in the anterior chamber or not, and then the put a PCIOL. Always better to go for the, now this is a SICS only, you can go for the, you can say, rigid IOL. Then the posterior capsular rupture with or without vitreous loss. So sometimes what happens, here you can go for the Amar Agrawal's technique, and then you can have a, you can say, the different type of surgery. You can keep patient aphakic if there is any tear or like that. Post-operatively, the early AC is flat, hypema, iris prolapse, endophthalmitis, and late it is astigmatism. So that also you will have to see. Then you can see the corneal complications. Also see here the cornea burns, the cautery or thermal burn is there, infection, descemet stripping, endothelial damage. When there is a descemet is separated, so you can do on the second day, but maximum, as the Namrata says, it can be done up to 1.5 months. But after that, it is not possible to repose the descemet. So early is the best. So you can do that. And the complication due to the instrumentation, you can say iris injury because of that, endothelial damage, descemet strip. Maximum time this descemet strip happens because of the, you can say, the instrumentation only. So, so I think the here the conclusion is surgeon must have thorough knowledge of all the possible complication problems that may arise during the surgery, so that they can minimize the incidence of their occurrence, and if they occur, they can be managed well. Thank you very much. Thank you, Namrata. Thank you,
Thank you, sir.